So thank you, Tom, and welcome, Dr. Shah, and thank you for speaking with me today. I'd like to start with a brief maternal health 101. Where are we as a country, and in your role and your research and serving as an obstetrician, where do you think we have challenges and opportunities as we move forward?
Thank you, Priya. Thanks for having me, and thanks for giving me the opportunity to do what I enjoy most, which is profess as a professor. Maternal health is a bellwether for the well-being of society as a whole. So if society is unwell, moms are unwell. If moms are unwell, society is unwell. And that's why you see every form of injustice show up in maternal health, whether it's racial inequity, gender inequity, geographic inequity, particularly in a post-Roe world, and generational inequity. A mother living in the United States today is 50% more likely to die in childbirth than her own mother was. Generally speaking, from one generation to the next, we'd like to leave things better, not worse. This is one area where I think it's one of the leading indicators, actually, that I think hope and opportunity in our country is starting to erode. And we see that in some of the political messaging, whether it's Build Back Better or Make America Great. And a lot of that is driven by that inequity that I spoke to. So if you're Black in America, you're 3 to 4 times more likely to die in childbirth. And of course, mortality is the tip of a really deep and wide iceberg, right? People have goals in childbirth other than surviving or even emerging unscathed. So in quality improvement, especially, for hospitals, we think a lot about safety, and understandably so. So there's a lot of morbidity in maternal health too, but people deserve to be supported and empowered too. And that's yet another way that we're falling short. Moms are socially isolated, they're economically disempowered, and generally struggling.
Yeah, so it's not a good conglomeration of impact and effect right now that we have when we look at the maternal health space. But one of the reasons I'm so excited to speak with you is that I lead our strategic initiatives work at the AHA. And so we work on maternal and child health, but we also work on value and affordability. And you have written a textbook on value based care. And while I don't want to dive too deep into value based payment, are there any insights that you can share for our listeners on what it'll take to improve the value of care that is offered to moms and their families?
Absolutely. Yeah, not good is definitely a euphemism for the status of maternal health. And I really appreciate that question because, look, childbirth is like nearly 1% of the entire GDP. If you take the entire GDP of the United States of America, you spread it out across the table, just the cost of hospitalizing mothers and babies is visible to the naked eye. It's 25% of all hospitalizations, a mom or a baby. And yet, we see the outcomes that I described. If you were to pick 3 really tough statistics, I think, for maternal health, it would be the maternal mortality one, right? Mortality has gone up significantly. Infant mortality for term infants has not changed, but cesarean rates has gone up by 500%, 500% generationally. So we're intervening with major surgery, and yet it's a rescue surgery, but infants on average are not better off if they're full term, and moms are worse off. So from a value perspective, that seems like a huge opportunity. And for people who are a little bit wonky, we think about like episodes of care. There's not a better defined episode than pregnancy. And yet we're so far behind when it comes to these value-based shifts. So big opportunity there.
Yeah, and we think about value not just in the payment concept, right? But how can we make changes in how we deliver care to improve outcomes, enhance patient experiences, and lower costs? And I think there's a tremendous opportunity to do that in this maternal health space. So, going back to maternal health specifically, can you share more about Maven and tell us a little bit about your patients, about the care delivery platform, and the services that you're offering?
You bet. And just to amplify your point for a second, that experience is part of the value equation. I think historically, traditionally, we've thought about safety very narrowly. And we almost treat experience as a secondary luxury that you get to after you've made people safe, which is why we subject them to like hospital johnnies and all the indignities. But what maternal health and racial inequity in maternal health teaches us is that actually we got it backwards. Like the way that you make people safe is actually by attending to their lived experience. And that's what's not happening. They're not feeling seen and heard. They're not being attended to. And that's what Maven's about. Actually, the entire value proposition for Maven is to solution for the fact that in the brick and mortar healthcare space, there's only so much you can get done in these punctuated 15-minute visits, particularly when you're trying to make sure people are affirmed and supported. So we're the largest digital clinic for women's and family health in the world. We take care of people from really across the reproductive health spectrum, but primarily people who are in the process of building their families. That's essentially the premise.
Great. So you recently, you've been around for a while now and treating a lot of patients, and you recently conducted research to look at how Black members were using your platform. So why did you decide to do this, and what did you find?
Thank you for asking that question. I mean, so when we talk about maternal mortality in the country, it's impossible to talk about it without understanding that racism and maternal health care intersect, and that Black moms are suffering most. Even when you account for income and education, even if you're Serena Williams, you are at risk if you're a Black mom in a different way. Anti-Black racism is particularly pervasive, and it's actually embedded in the way that we practice medicine. It's not that like necessarily that individual doctors are bad people. It's structural and systemic. But for that reason, it was important for us to understand how our Black members are doing. And one of the things that we found, the promise of digital health should be not to replace the things that are happening in the brick and mortar setting. I'm an obstetrician, I'm pretty tactile. You can't deliver a baby through a screen, right? You should be doing the things that are only possible when physical proximity isn't a constraint. So what we're able to do is connect moms to doulas and lactation consultants and people who may not be proximate to them. And so what we see is our Black members are 50% more likely to use doulas and significantly more likely to use all of our providers. I suspect that that's because hopefully we're doing a good job of earning their trust, but also because in the brick and mortar setting, they're facing a lot of barriers.
Yeah. One of the things I read sort of in the findings of your research was that virtual care has the high utilization among Black parents, and you just touched on that briefly. Our team has also been doing some work around digital health equity and ensuring that individuals can actually access digital solutions. So that includes not just having Wi-Fi or having a smartphone or an iPad, but also, having that culturally sensitive product that members can use, or having it even be at the right reading level so that they're able to understand and comprehend the solution. So how do you look at this, especially given the finding that Black moms are using these solutions more? Or how are you looking at digital health equity?
That's a really great question. I mean, I think, we take care of Medicaid recipients. And that means we have to take care of people who often don't have great means. And often, people make a lot of assumptions about sort of digital literacy that we don't necessarily find to be the case. That being said, you need to have a way of making sure that you're not just supporting people with the right technical expertise, but the way to affirm people's dignity is to have shared lived experience. So as CMO, all of our providers roll up to me. So I'm in charge of recruiting our providers and what our staffing looks like. So it's really important to have a workforce that looks like the people you're serving. 40% of our providers identify as people of color. Nearly 10% identify as LGBTQ+. We make sure that we have providers that can speak the right languages. So like if you speak Spanish, we can speak Spanish. And that's a really important part of taking care of somebody well.
Yeah, I think all of that is really great. And, we're seeing hospitals try to tackle those same challenges, right, as they're providing care in the bricks and mortar setting. And you've had a lot of different experiences in your career. Are there things that you have learned or advice that you have for hospitals and health systems as they work to improve maternal health?
Oh, always. But I think, look, a bad system will beat a good person every time. I think that's pillar number one. And pillar number two is that every system is perfectly designed to get the results that it gets. So I think we're at a moment right now where hospitals and everyone on the front lines of healthcare delivery is necessarily taking a hard look at these systems that over the last 3 years have not served people well. And what COVID-19 really did is take every inequity in our society and throw it into a pressure cooker. So like you could see with your eyeball in our hospitals who was being most impacted. At the same time, it was not just the patients that were impacted, it was like the providers. I think 1 in 5 of us has left the profession or is strongly considering it at this moment. Whether it's for maternal health or really any other service line, a really, really important opportunity to close these gaps by taking a systems approach. That's ideally the way that we do it. Not that there's not individual accountability, but we need systems that make it easier to do the right thing, if that makes sense. Almost everything that we do in the hospital to drive improvement makes it harder to be a doctor or a nurse. It's like, here's one more box to check, as opposed to like, seriously, let's take a step back after 3 years of this pandemic and be like, of all the things we're doing, what are the things that actually serve people well?
Yeah, I heard one CEO describe it as every time we look at a solution, we add another checkbox or another thing for a physician or anyone on the care team to do. And if you imagine that every check that we give them is a piece of paper and you pile those up and then you turn them sideways, that's the distance that we're putting between our care teams and the patient. And that's the distance that is leading to them being unhappy in the workforce. And like you said, COVID just gave us the opportunity to see this front and center, right? Because the systems that we had in place before the pandemic weren't working. And as we try to get to this new normal, we have to completely change how we're doing it if we want to see the outcomes that we want.
100%. One of the most absurd examples of this, it became a meme on Twitter a couple of years ago, but I walked through my hospital with an architect and she asked me why every labor and delivery room had 7 trash cans. And it was actually the first time I realized we had 7 trash cans. And we like walked through them. It was like there's normal garbage, there was like recycling, of course, there was soiled linen, there was the biohazard thing, there was a yellow one that you put oxytocin in because you couldn't dump it down the sink. This is the hormone that makes people nice to each other. So I guess if it just out into the Boston water system, like that's not good. But we like counted, and it was like every
Yeah.
time someone had an idea, they literally added a new garbage can.
That is crazy and it's unsustainable, right? We talk about healthcare costs and burden to clinicians and patient experience for patients and all of it's not sustainable the way that it is. So I think we have a tremendous opportunity now to not just redesign care for mothers and their babies, but care delivery as a whole.
I agree. I also think that moms are a great place to start. I think historically, they have not gotten the attention they deserve for a few reasons. One is that Medicare generally doesn't pay for childbirth. There are not a lot of over 65ers having babies. And so, like, Medicaid didn't get cool, I guess, until relatively recently, and we're starting to focus on it. The other is it's just really easy, rather, to take moms for granted, I think, including if you are a mom. Like, moms are used to putting themselves last to put their families first. And so, like, the status quo for moms is generally what happens, as opposed to taking a hard look at it and trying to improve.
Right, absolutely. And I think, one of the steps forward is also to just work with moms so that they understand how to advocate for themselves in a different way than they have in the past and to prioritize themselves, to your point about moms just naturally putting everyone else before them. Because I see it with my mom every day, right? I'm sure you
Totally.
see
We
it
all
with
do.
yours too. Yeah.
And just a provocation for the hospital leaders listening to this: a living will and a birth plan are the same thing. One is like readily understood by the hospital as a thing that is designed to surface people's sort of preferences, values, and generally get us to like tone it down a little bit. And birth plans are really the same thing, but often they're seen in adversarial terms inside of hospitals rather than doing exactly what you said, which is making sure that moms are well supported and that not only they know how to advocate for themselves, but they're listened to.
Yeah, absolutely. That's so important. Well, Dr. Shah, thank you so much for being with us today and sharing your insights with our listeners. And to all of our listeners, thank you for joining us.
Thanks for having me.